Hello, and my name is Dr. Behrad Baharlo. I'm a consultant in intensive care medicine and anaesthesia at Hammersmith Hospital in London. It is a pleasure and a privilege to give the second in our series of talks to you at the British-Ukrainian Symposium this year. The talk is going to be on Haemophagocytic Lymphohistiocytosis, or macrophage activation syndrome as a clinical entity. Now, I work at Hammersmith Hospital, pictured here on the top right-hand side of the slides, where we are, amongst other things, a tertiary haematology and hemato-oncology unit based in West London. So whilst these syndromes are quite rare, we do see quite a number of these patients per year, particularly the critical care manifestation of these syndromes. So a reasonable place to start is to define exactly what it is that we are talking about. So is it HLH or is it MAS? Is it Haemophagocytic Lymphohistiocytosis or is it macrophage activation syndrome? Well, essentially, these two disorders or terminologies are essentially the same phenomenon that may lead to a cytokine storm. The difference really is the context. So it depends on whether we are talking to rheumatologists about rheumatological disorders versus haematologists about hematological disorders, where macrophage activation syndrome is typically favoured and used by rheumatologists and HLH by hematologists. Now, for the purposes of this talk, I'm going to use the terms interchangeably, but I'm going to use the term HLH, where HLH, so Haemophagocytic Lymphohistiocytosis, being the umbrella term. And in this context, macrophage activation syndrome is essentially a secondary HLH in the context of autoimmune or rheumatological diseases, for example, like but not limited to adult onset Still's disease or systemic juvenile idiopathic arthritis. HLH is a rare phenomenon. It was described initially in 1939 as a syndrome, so a constellation of symptoms which all had a unified feature of abnormal or dysregulated immune response to a trigger. So this abnormal dysregulated immune response is illustrated on this slide. But before we turn to the dysregulated response, it's worth having a look at what a normal immune response looks like. So effectively, the normal response involves a trigger, for example, an antigen like infection, malignancy, or an autoimmune disorder that causes activation of NK cells, and NK cells are cytotoxic T lymphocytes, which go through a process of maturation through to fusion at cellular level, ultimately targeting the target cell to kill that target cell. Now, the important thing here is that in killing off that target cell, you're removing the antigen and thus terminating the immune response. However, in the dysregulated response, you see that there is the trigger. There is ultimately an uncontrolled immune activation involving NK cells and cytotoxic T lymphocytes, causing immune cell proliferation, activated macrophages, and ultimately hemophagocytosis, causing a milieu of hyperinflammation and a cytokine storm involving numerous different pro-inflammatory cytokines. This milieu of hyperinflammation is what gives us our clinical presentation, and ultimately our supply at its most extreme of organ failure and organ dysfunction. Traditionally and classically, the concept of HLH has been classified as being either primary or secondary, with primary HLH being typically caused by inherited disorders and disorders of gene mutations, seen mainly in the pediatric population. Secondary HLH is typically HLH as a result of secondary to an underlying trigger, for example, infection, malignancy, or infection. But there has been evidence to suggest that there is a genetic involvement in regards to secondary HLH, to an underlying genetic tendency that causes the patient to predominate towards a dysregulated response. And this has led to the concept of what is called the threshold model of secondary HLH, where we feel that genetic factors are underlying, but in the presence of treatments of immunosuppression or inflammation or additional triggers like malignancies or infections, crosses a threshold where the autoimmune immunological response goes from being controlled and regulated to uncontrolled and dysregulated, causing what we see as HLH or phenomenon thereof. So how do we make a diagnosis of HLH? Well, traditionally, HLH has been diagnosed using the HLH 2004 diagnostic criteria. These criteria are set out in this slide, but in short, it involves either establishing a molecular diagnosis consistent with HLH, or 5 out of 8 clinical phenotypes involving fever, splenomegaly, cytopenias, hypertriglyceridemia, hemophagocytosis, bone marrow, or low or absent NK cell activity, ferritin levels over 500 grams per litre, or soluble CT to 25 counts above 2,400 units per mil. This criteria was actually developed in the paediatric population with primary HLH patients, and there's no prospective validation in adult cohorts. So how do we make the diagnosis in the adult cohort? Well, the cornerstone of diagnosis in adults is the H-score, which has been validated in adults, but also in the critical care population, as I will soon describe. The H-score is widely available on online medical calculators, like, for example, MD-Calc, and it utilizes up to 9 different clinical parameters and attributes a score or weighting to them. For example, known underlying immunosuppression, temperature, presence or absence of organomegalies, cytopenias, absolute ferritin levels, triglyceride levels, fibrinogen counts, serum glutamic-oxaloacetic transaminase, if indeed your laboratories measure these, and the presence or absence of hemophagocytic features from bone marrow aspirates. Now, in applying a weighing or a score to each of these parameters, you end up getting the H-score, and the H-score has been validated to attribute to a probability of hemophagocytic syndrome. So the higher the H-score, the higher the probability of the presence of a hemophagocytic syndrome. And clinically, both for hematologists looking after these patients on the wards, as well as intensivists, we use a cutoff of 169, the best cutoff corresponding to a sensitivity of 93% and specificity of 86%, to accurately classify 90% of patients with HLH. So a score of 169 is typically used as the cutoff. So whilst the H-score and a cutoff of 169 picks up to 90% of patients with HLH in a general population and is favoured by our haematology colleagues, the H-score has also been validated in critical care populations with improved pickup in critical care populations with higher cutoff of over 200. This French group here established that the diagnostic performance of the H-score in our populations is markedly improved the higher the score is. So we have a diagnostic problem in the critical ill, and that is that none of the criteria that is found in the H-score is specific to HLH. In fact, all of the criteria are raised some way or other in a general critical care population. For example, fever, cytopenia, hypertriglyceridemia, raised ferritin levels, and even hemophagocytosis are not unique in the critically ill population, and they're certainly not uniquely diagnostic of HLH in our populations. They all, for example, mimic sepsis. What of hyperferritinemia as a diagnostic marker? Well, a raised ferritin level and hyperferritinemia is a pro-inflammatory marker. It is, again, raised in critical illness. It is itself a compounder. It is compounded by sepsis, hematological malignancy, AKI, and acute liver injury. However, a high serum ferritin level, particularly that of over 10,000 milligrams per litre, is highly sensitive and specific for diagnosing HLH and monitoring disease activity in the critical care setting and in critically ill populations. And this strategy is shown here elegantly in this study, which looks at hypothyroidism in particularly ill patients, where a cutoff of 9,083 micrograms per litre gives a sensitivity of 92.5% and specificity of 91.9% for the diagnosis of HLH. See how it compares to other diagnoses that we find on the critical care unit, for example, sepsis and septic shock, or even sepsis without shock, where ferritin levels are raised, but not to the extent that we see in HLH. So this higher cutoff point is a good way of delineating HLH from other confounders that we see in confounding diagnoses that we see in the critical care population. As such, this cutoff point of around 9 to 10,000 micrograms per litre has also made its way into guidelines around the diagnosis of macrophage activation syndrome in secondary HLHs in adults, as defined by this diagram here, where an adult with a Pyrex of unknown etiology and origin in an at-risk population with a ferritin level of over 10,000 micrograms per litre is delineated as being the most probable, where further investigations are required and indicated. So what are the clinical features of HLH, and what are the features that I typically see in my clinical practice? Well, we talk about the 3Fs as being the common features. That's our fever, falling counts, and ferritin. Now, I must commend the sign of fever, which is pretty much almost always present, and fever that is always refractory. So think about the fever that just simply won't go away despite courses of antibiotics and interventions. Haemophagocytosis on a blood film or a bone marrow lymph node or spleen biopsy may actually be absent, and it's actually absent in up to 20% of patients in HLH. Cytopenias do occur, and ferritin counts of over 5,000, but as previously mentioned, above 10,000 would make it more clinically indicative of HLH in the critical care population. We also see significant coagulopathies and hyperfibrogenemia. And hyperfibrogenemia in the HLH cohort is a poor prognostic marker associated with decreasing survival and an increasing risk of occult bleeding in the gastrointestinal tract, in the lungs, and in the brain. HLH is associated with organ failures, with acute respiratory failure making up to 75% of the ICU cohort, followed by cardiac failure and renal failure, to 50 to 70% of the ICU cohort. But at its most extreme, it can involve all organs, including the brain, liver, skin, and the gastrointestinal tract. So what are the causes or triggers to secondary HLH? Well, typically infection of a variety of causes, cancers, both hematological and non-hematological malignancies, autoimmune disorders, but actually there are a wide variety of underlying triggers involving drugs, even surgery, vaccines, pregnancies, bone marrow transplants that can potentially cause secondary HLH. A review of 1 year survival of patients diagnosed with HLH in England between 2003 and 2018 showed that of 1,628 patients, about 28% of them had an underlying hematological malignancy, 23% of them had a non-malignant pro-inflammatory or autoimmune disorder, or for example, a rheumatological disease, and about 6% of them had a non-hematological malignancy, for example, a solid organ tumour. From the data from the same nationwide cohort study from England between 2003 and 2018, we know that the incidence of HLH is increasing, and there has been a four times increase in incidence between 2003 to 2018, which essentially is an 11% annual increase. Why is this? Well, there are probably a number of factors involved here, and including the increased diagnoses of the young, particularly with autoimmune diseases, along with more novel treatments that may be precipitants or triggers to secondary HLH. Increasing age with increasing numbers of elderly with hematological cancers, for example, non-Hodgkin's lymphomas, and their treatments, which can be triggers for HLH. Ultimately, there could also be an increase in recognition and our abilities to actually diagnose HLH compared to years gone by. Furthermore, the acquiring or reactivation of EBV virus, particularly during treatments associated with COVID morbidities, has been cited as a potential reason for increasing incidence. Ultimately, we know that it is out there, it does occur, and it is increasing in its population incidence. So why do we need to know about HLH, and why do we need to be able to identify it? Well, in that same nationwide cohort study from England, we find that the outcomes are poor. So the all from a population through 1 year survival was only 50%, with an increasing risk with increasing age, with patients of a male sex, and also patients whose HLH was triggered due to an underlying hematological malignancy. Other risk factors for mortality really can be summarised as those with an underlying hematological malignancy, as well as male patients and those certainly above the age of 55, but the presence of and severity of the thrombocytopenia and that of a disseminated intravascular coagulation also are significant risk factors towards mortality or survival. And as an underlying cause across increasing age, we know that the younger paediatric populations are more likely to suffer a primary or an inherited or genetic HLH, whereas those of a sort of an interval age are more likely to have an infective or viral or an autoimmune inflammatory trigger, whilst those who are older are more likely to see HLH in the context of malignancies, whether hematological or other. So how do we go about our diagnostic workup for these patients? Well, I must commend a multi-speciality, multidisciplinary approach to diagnose the syndrome and ultimately identify the trigger. And in diagnosing the syndrome, this occurs by virtue of standard blood tests, but also daily H scores. I can't commend highly enough the scoring of the H score early, but also repeated daily to look at your trends. In collaboration with our partner colleagues, whether they're hematologists or rheumatologists, we will be collaboratively hunting for an underlying cause, whether this is infectious by virtue of tumor cultures, viral PCIs and serologies, imaging, or utilizing bone marrow or tissue biopsies, along with any immunological and genetic testing. Bone marrow biopsies are actually not used to screen for HLH, and the reason for this is that there is no universal agreement as to the extent of hemophagocytosis that needs to be present on bone marrow biopsy to diagnose HLH as a syndrome, and also the fact that a biopsy which is devoid of hemophagocytosis is not necessarily able to rule out HLH as an underlying trigger, or indeed if there is hemophagocytosis present, the presence of HLH, because it very much depends on when, during the time course of the underlying pathology, the biopsy has been taken, and in particular the time course in relation to any interval interventions or treatments that have been given. Bone marrow biopsies, timed appropriately in collaboration with hematologists and rheumatologists, however, can be very informative, particularly around response to therapies. But ultimately at Hammersmith, we have a mantra, depending on who you're talking to. So if you're talking to our hematologists, as our diagnosis is lymphoma until proven otherwise, and if we're talking to our rheumatologists, our underlying diagnosis is lupus or vasculitis until proven otherwise. So how do we go about treating HLH? Well, the treatment strategies as follows. It is to treat the underlying condition, whether it is the infection or malignancy with chemotherapy, for example. But the cornerstone to treatment whilst we are treating the underlying condition is to try and reduce the hyperinflammation that causes organ dysfunction and multi-organ failure. And this involves combination therapies, for example, utilising corticosteroids, IVIG, cyclosporin, or etoposide. Now, the traditional acute treatment is always the triple therapy of dexamethasone, etoposide, and cyclosporin A, known as HLH94. But in the UK of late, there is a tendency now to move away from this traditional treatment and use steroids and etoposide sparingly, utilizing more novel targeted therapies, for example, like anakinra, which is an IL-1 receptor antagonist, ruxolitinib, which is a JAK inhibitor, or alemtuzumab, which is a CD52 T-cell inhibitor. You can see that these targeted therapies specifically target cytokines and pro-inflammatory interleukins, which participate in this uncontrolled immune response, and in doing so try to inhibit the proliferation and the dysregulated immune response between the trigger and hyperinflammation that results in the multi-organ dysfunction and the clinical sequelae that we see. A typical treatment strategy for secondary HLH or MAS in the UK would involve using an IV methylprednisolone and IVIG as initial primary therapy, moving on to second-line treatments, for example, anakinra, a dose of 1 to 2 milligrams per kilogram, increasing to up to 8 milligrams per kilogram per day as second-line treatments, and then using or keeping a etoposide treatment for refractory cases and third-line therapy as third-line therapy. Concurrently, any EBV related disorders or triggers are considered for rituximab, as well as any targeted antibiotics to treat infectious underlying triggers as well are bestowed at the same time. Anakinra is an IL-1 receptor antagonist whose use as a treatment for HLH has been expanded in the UK, certainly over the last few years. There's now generally accepted treatments, particularly around second-line treatments in patients whose HLH remains refractory to steroids and or IVIG. It's worth noting that etoposide is reserved typically for steroid and anakinra-resistant HLH, and is predominantly prescribed in conjunction with hematologists with careful dosing. Cyclosporin is now typically used to prevent HLH relapses, particularly in rheumatic disease-related cases. So in summary, HLH is increasing in incidence and it comes with significant mortality risk. I would commend an MDT approach to particularly identifying cases, identifying triggers, as well as treatments. And really, the early recognition and the treatments of HLH early allow successful resolution, particularly with modest therapies or relatively modest therapies like steroids and anakinra. And ultimately, the treatment tapering should focus on minimizing potential morbidities vis-a-vis these treatments, for example, side effects from steroids, anakinra, and obviously, the chemotherapy drugs like anastrozole and so on. We at the Hammersmith work as part of a wider specialist tertiary team, but there are a number of national MDTs that take referrals from centres all over the country to give advice about refractory cases of refractory HLH where the diagnosis is particularly unclear or the patient's condition is either complex or very critical. And these national MDTs are commended in the HLH GLIFT document here, which I would commend to anyone who is interested in some further reading as part of our guidance strategy in the UK and standard for diagnosis, treatment and management of patients with HLH. Once again, thank you very much for your attention and your kind invitation to speak at your conference. I do dearly hope that one day I will be able to visit Ukraine and Kiev and attend your meeting and your conference in person.